All right, everybody. Thank you for being here today for our webinar on sexual abuse and PTSD in multi-plaintiff litigation. Our guests today, or our co-hosts today, are Dr. Mark Levy. Dr. Levy is an associate clinical professor of psychiatry at UCSF. He's a board-certified forensic psychiatrist and the medical director for Forensic Psychiatric Associates, LP. Charles Saldanha, Dr. Levy's partner, is an associate clinical professor of psychiatry at UCSF. He's a board certified forensic psychiatrist, and he's the assistant medical director for Forensic Psychiatric Associates, LP. They are both long-term members with Experts.com, been good friends, and we've done some other webinars with the team in the past. And this is where I'm going to turn it over to you. Welcome both to this webinar. Thank you for being here. Thanks for doing this. And I will turn it over to you, Mark.
Thanks so much, Nick. And thank you to Experts.com for hosting this. This is a topic that we're really quite interested in. We've done a fair amount of work in this area, and we enjoy talking about it, and mostly we enjoy getting questions. So what we're going to do is give a fairly thorough overview, but certainly this is not the comprehensive advanced course. It's an overview with the hope that that will stimulate questions and discussions, because I find that much more relevant to everybody's practices than my giving a lecture. So as Nick said, Dr. Saldanha and I are both the assistant medical directors of a unusual group. We're 19 forensic psychiatric and psychological experts, 12 forensic psychiatrists who are all board certified in forensic psychiatry. All of us are on clinical faculties of major teaching hospitals, and 7 forensic psychologists, 6 of whom are neuropsychologists, one's an autism expert. But because we are unusual in that we are a team, we've had the privilege of being retained in a couple of dozen or more multi-plaintiff cases. And that has given us a perspective on that challenging but very interesting dimension of litigation. So we're going to talk about sexual abuse. We can go to the next slide.
Sure.
We're going to talk about sexual abuse and somewhat particularly about child sexual abuse, because as most or all of you know, there's been a dramatic change in recent years where people who were sexually abused as children, as minors, and were blocked from litigating for the damages they sustained, that statute of limitation that had told is now extended in about 40 states. So we're going to talk about the legal and clinical definition of sexual abuse. We're going to talk about the differences. There's a spectrum: abuse, assault, harassment. These are related but not identical. And a bit about the prevalence of this problem amongst female and male victims. Next slide, please. So as you can see here, this is a color-coded map. And what it highlights, what I'd like you to see, is that there's new laws about the statute of limitations regarding child sexual abuse claims in 24 states. There are bills that are introduced in 41 states. Only 10 of our 50 states have no activity, and there's been a revival of the window, really a revision of the window that's been opened to revive these claims in 9 states. Next slide, please. Okay, so what is child sexual abuse? This is really a definition that is influenced by a variety of parameters. Uh, the nature of the abuse. Um, for example, uh, there's a difference between a one-off fondling event and a child who is being sexually abused, fondled, even penetrated, uh, involved in oral copulation over an extended period of time. Um, and the issues pertaining to the nature of the abuse, who is the abuser, and the vulnerabilities of the victim are all relevant to the ultimate outcome. So the context, is this a stranger who touches a child in a playground on a single occasion, or is this a beloved uncle or the boyfriend of mom who's living in the home and repeatedly traumatizing the child? We're going to say something about the risk factors and the protective factors. We call that resiliency factors, and those have a lot to do with the historical background of the child and the kind of developmental history they've had growing up. How sound versus how troubled is that? Their socioeconomic contexts, although uh, you must know that sexual abuse crosses all classes, uh, all races and ethnic groups, and really all socioeconomic categories. And the psychological factors. And then, of course, mention that there's treatment for sexual abuse, uh, even if that treatment doesn't occur until years later when the person is no longer a minor and has been, in fact, struggling with the consequences of what happened to them for a number of years. Next slide, please. Okay, so the consequences of trauma. Now, this is all trauma, not narrowed down to sexual abuse, child or adult. The most common consequences are symptoms of depression or formerly diagnosed depressive disorders and substance use and abuse. Drinking too much would be substance use, and substance abuse is becoming dependent upon alcohol or other mind-altering substances. These two are the most common um, after effects. The medical term is sequelae to post-traumatic stress disorder. So this is all, these are all parts of a whole. So PTSD is the most severe diagnostic consequence of trauma. And we'll talk briefly about PTSD. I don't want to spend too much time on the nuts and bolts of PTSD diagnosis because that can be an entire other discussion. But PTSD is a response to trauma, and a less severe response to trauma is an adjustment disorder. Both of those are a response to a specific event or condition, or it could be an ongoing occurrence or a single catastrophic occurrence. Another consequence of trauma is no diagnosis, and that's in many ways the most interesting from a clinical and from a research perspective. Why is it that some people have experienced a really bad foundation shaking trauma and do not develop disabling psychiatric conditions? This doesn't mean that they're oblivious to it or that they are not disturbed by it or don't have recollections of it, but they're not functionally impaired. And then, of course, the most important dimension to look at in terms of um, prognosis is the possibilities for treatment and recovery. Next slide, please. Okay. Uh, Post-traumatic stress disorder has these A through H criteria. These are diagnostic criteria. The standard document, which I'm sure many of you are familiar with, is the Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association. It's not just national, it's international, and is the standard for codifying mental health diagnoses. And it has various kinds of matrices in it by which diagnoses are made. And the most common are these alphabetic diagnostic criteria. If you went into the DSM, you'll see much more qualifying sub criteria under each of these letters. I'm not going to belabor this now. The most important takeaway is this: PTSD, the diagnosis of PTSD, has a threshold criteria. And the threshold is that the individual being diagnosed needs to have been exposed to actual or threatened death, serious injury, or sexual violence. There is an important carve out here, which pertains to child sexual abuse, and that is when a child has been significantly abused sexually, like the hypothetical I was suggesting, the beloved uncle who, or parent, or uh, partner of the other adult parent, is repeatedly um, sexually abusing a child, that qualifies. And here's why: because explicitly, or sometimes just implicitly, in the relationship between the abusing adult and the abused child is an understanding, which is sometimes explicitly stated, that this is our secret, this is our special relationship, and you mustn't tell anyone, because if you do, terrible consequences may develop. Mommy may be sent to jail, or you may be sent away from mommy and put in a home, etc. And that kind of threat to a developing child is regarded by my field as equivalent to a life-threatening event in an adult. That's the
It,
most. Sorry.
I just wanted, so even though the threshold in the, just for the point of clarification, Mark, even though the threshold in the DSM-4 says exposure to actual or threatened death, this this threat that mommy or daddy might be sent away or go to prison, that's an equivalent thing for a child to experience.
Yes, and in fact, I haven't given you a full copy of the DSM-5's diagnostic criteria, but
Okay.
there is, in fact, an explicit discussion of child sexual abuse. So it's not, this is not my idiosyncratic inference. This is in the document.
Okay, great.
Yeah, just to quickly tie it to something Mark said earlier, I think the foundation shaking aspect of what the consequence of sexual abuse, like the sort of hypothetical that Mark shared, would be, that might resonate with the audience, that this has a similar sort of highly disruptive effect on a child's sense of safety and security in the world.
That makes sense. That makes sense.
Right.
Thank you for that clarification.
Okay. And so let's go on to what is PTSD and what is not PTSD. We've said something about, if I go back a slide,
Sure.
go back one slide, the B, no, one more slide.
One more.
Sorry.
Sorry
Yeah.
about that.
Yeah, it's okay. The B through H criteria or other criteria, they in general are re-experiencing criteria, avoidance criteria, um, physiologic hyperreactivity criteria, duration criteria, etc. But if you don't have the A criteria, the threshold, you don't have PTSD. The person may have some other diagnosable psychiatric condition, but it's not PTSD. That's a threshold. And it's like, you can't have a touch of pregnancy. You're either in or out. And that's the way it works medical legally for PTSD. So now going on to the next slide, and you can click through that so we see the full slide. Um, the many people, majority of people have experienced a traumatic or stressful event if you've lived enough decades on this planet. But what is remarkable, that even when you get to severe traumatic events, such as a violent rape at gunpoint or knife point, as many as half of the victims of those experiences do not develop PTSD. And then they may develop a lesser diagnosis like adjustment disorder, or they may develop nothing, but they do not develop PTSD. And that is very interesting. Why is that? Next slide, please. And you can click through that. The reason is resiliency factors. And resiliency factors have been a complex area of study in our field for the last 20 to 30 years, really since starting with the Vietnam War, but certainly for the last 20 years or so, there's been vast sums, billions of dollars funded to the VA, which is a major arena for such studies because so many veterans have experienced PTSD. What are the resiliency factors? And next slide, please. What is resiliency? And you know, it's very difficult to define. There are characteristics such as strong, supportive, early developmental experience, feeling loved, feeling that your environment is safe as a child, feeling that parents are consistent and reliable. It's not a function necessarily of financial parameters, although obviously if you're growing up in poverty, it's more difficult to have a sense of security. But basically, as Potter Stewart said about pornography, I know it when I see it. And we all have experienced people who are extraordinary. You know, they are not typical. They're the exception that proves the rule, but who have overcome incredible adversities and flourished. They're very admirable. And so within the population of people who experience severe trauma, there are those of us who fortunately have had solid psychological foundations and we're able to, and we are able to often, not always, weather these terrible life-threatening storms. Next slide, please.
Oh, right.
Okay,
So
I think I'm,
yeah. My colleague Charles Saldanha is going to take over at this point. And let me just say one thing. I didn't I missed talking about something about the prevalence and the incidence, but maybe we can go back to that at the end.
yeah, and just in case we find ourselves short of time, I think you know what Mark and I would like to make sure is clear is that sexual abuse is not a rare problem, and it's you know, common enough to be, I think, fairly characterized as a major public health issue. And so you know, it's a common thing that we see in our clinical practices, people who have this as a part of their background, which is very relevant to what they're bringing to us as patients, and certainly you know, in terms of the we do a variety of cases in our practice. Sexual abuse is you know, it's not one of these calls we get you know, a couple times a year or even a couple times a month. You know, these are very common referrals that we're being asked to evaluate, and really for both sides of the bar. So a little bit about how we actually go about doing forensic psychiatric assessment of these sexual abuse claims. And I actually want to start with something that is just important. I think it may be evident to some folks who are on the call, but really the first point I really want to emphasize is that our role in doing these assessments is very different than that of a clinical provider. And that's what we refer to as this two hats problem. Next slide. Nick, if you could move to the next slide. Thank you.
Go? Are you seeing it yet?
Now I see it. There we go. Good. Yeah, so the reason we talk about this two hats problem is that there is a significant difference in the mission, what we're actually trying to accomplish, how we go about accomplishing that, and our ethical duties when we're in the role of a treating clinician, as opposed to when we're serving as a forensic expert in litigation. Next slide. So all of us in our practice, we all have clinical practices, and when we engage folks in that context, our goal explicitly is to alleviate the suffering of that individual that we're serving. Okay, and how we go about that, it's almost exclusively based on what the patient brings into the sessions. It's their subjective reality. We are working with their narrative. It's not to say we never look at some previous records or never get testing or so on and so forth, but with very rare exceptions, the primary data source is what the patient reports, what complaints they have. We're almost exclusively working with the subjective reality of that person. And in terms of our ethical duty, for us as psychiatrists being physicians, it's sort of founded in the Hippocratic Oath. It's to that patient, first to do no harm, and then we see ourselves in the clinical role as advocates for that person, the patient's best interests. You know, there are some narrow exceptions to that, duties to third parties in the setting of duties to warn and so forth, but they are the exceptions that prove the rule. Next slide. So contrast that with how we approach our role when we are retained as an independent forensic expert. So whereas we're in a clinical setting trying to alleviate suffering, when we are working as forensic experts, our goal is to determine what is objectively true. And our method is much more comprehensive in terms of the data that we rely on. We certainly, as part of a evaluation, we will do an IME interview. It's generally of many hours, and I'll talk a little bit more about how we approach that. We get testing, and we try and review all sources of relevant data, be it medical records or other types of records. I think there's one more bullet there.
Is there? There we go.
Yeah, there we go. And our ethical duty when we are in that role of a forensic expert is to the trier of fact to provide the best possible evidence-based opinion. Again, we're trying to determine what is objectively true, not alleviate suffering as a treater would in the context of the patient's subjective reality.
And I have a question on this, Charles.
Sure.
In the forensic assessment, and I should note, folks, that who showed up a little later, the Q&A is open. We have left a lot of time for question and answer. So if you want to start posting your questions in that Q&A, please go ahead. We've got about 10 or 15 minutes left on the presentation, but we are going to have plenty of time for Q&A afterwards. So go ahead and start filling those in if you have them. My question in this situation, Charles, is through your evaluations in this forensic assessment, are you able to offer opinions on the credibility of allegations of sexual abuse?
That's a really good question. And actually, I think the next slide might get into that a little bit. I'm going to talk at some length about our methodology. And I think that might be the best way to sort of speak to how we can assess things like credibility and validity of reports.
Okay, great.
Could I just add a brief comment here? What you've said, Charles, is really important. All clinicians, including Dr. Saldanha and myself, accept the subjective reality of our patients unless they're off the charts, unless they come in psychotic, telling us that there's a Martian with a ray gun pointed at them. So when a patient comes to me and says, my father beat me, or my father molested me, I go with that subjective reality. But that's very different from the role of an independent forensic psychiatric expert who is, by definition, a professional skeptic. And so the task is to question this and to look for corroborating evidence. As a treater, I don't get collateral interviews from family members to see whether Uncle Jack was a molester or may have been. I accept my patient's self-report. But as an independent forensic psychiatric expert, I have to look at collateral information as much as I can get a hold of in order to determine, is this probable or improbable? Thank you.
Yep. And just as we are on this slide, as Mark is alluding to, we will review records. And again, it certainly is a clinician. Sometimes we'll get previous medical records, and certainly it's very rare that we get all the previous records. As forensic evaluators, that's what we want. We want to look at somebody's pre-morbid history, the records that are around the time of the incident, and anything that's come in after the fact. And in terms of that, looking for corroborating evidence, sometimes there are multiple reports of what had happened. Now, it's not to say that people's reports aren't literally going to be verbatim the same across things, but are there vast differences? That's the kind of thing we're looking for, and we'll call that out. We're certainly don't have a sort of built-in lie detector ability or ability to go back to that event and somehow precisely reconstruct what happened, but there may be some way in which we're gleaning and as part of our evaluation, noting these kind of differences or consistencies in report of what had happened.
And we never wear both hats.
That's right, and that's I perhaps didn't call that out quite as clearly. That as Mark mentioned, all of us work as clinicians and in our practice of where we function as expert witnesses, but we don't do that in the context of providing expert witness services. So we would never go on to treat a person we evaluated in a forensic context, nor would we serve as a expert for one of our patients that we treat in our clinical practice. In terms of things that we review, records, not just psychiatric and therapy records, we're often very interested in general medical records. I can think of cases in which really some of the most compelling evidence of how the event in question has impacted somebody's functioning is actually found in primary care or even OB-GYN type records. There's a need to not just look at the things that are explicitly psychological or psychiatric in nature. And often we're looking at things like educational or occupational records, in the area of child sexual abuse. That's a very common sequela is a marked fall off in academic performance in the wake of sexual abuse. Is there recovery of that fall off? We're looking for things like that. And then vis-a-vis legal documents, we certainly want to look at the complaint and the pleadings. We want to look at depositions, certainly of the plaintiff, him or herself, but also others who might have insight on what had happened or on the person's functioning over time. Often, just to sort of draw the contrast, sometimes the treating clinician is a very valuable fact witness about what had happened, and so their deposition might be relevant as well. I do want to say something about psychological testing now, and that is something that does have some bearing on looking not so much at validity of reports of what happened, but perhaps looking at validity of how somebody's describing their complaints. In our practice, we use, typically in a case like this where it's usually psychological tests, it's usually not a role, though there can be exceptions for neurocognitive testing in these types of settings. And our psychologists in our group, they will use multiple tests and tests of multiple modalities. So what I mean by that is they will use objective tests, kind of questionnaire-based tests like the MMPI and PAI, if you're familiar with those. And they'll also give a test that's called a projective test, something like the Rorschach. And the Rorschach is that ink blot test, which may, based on some people's sort of understanding, seem like something of a Ouija board, but actually it is just as robust in terms of its ability to yield valid results. It's administered in a standardized way and scored in a standardized way. And what testing allows us to do is to look for consistency across different tests of how people are describing themselves. Testing is ultimately an exercise in trying to determine what group is this, what subgroup does this person belong to? How are they responding? What are their responses like? What diagnostic category tends to yield responses like this? And in terms of validity, these tests have robust validity skills, the ability to determine both features consistent with underreporting of symptomatology and also overreporting, potentially that someone is overemphasizing emotional distress. A quick word about testing. We feel very strongly that testing ought to be done by a trained neuropsychologist. There are some psychiatrists who do their own testing. Certainly there is some training available, but we really believe on somebody with the gourmet level of knowledge administering, scoring, interpreting these tests. And what it also allows us in our evaluations is to have sort of a case conference, which is ultimately how we work in clinical medicine as well, that we kind of put our heads together and really come up with the best possible sense of what is going on based on these converging streams of data. And so lastly, I'll turn to the forensic psychiatric interview. So the forensic interview we do usually lasts between 4 and 6 hours, and it is not a deposition. So one thing I want to be clear about is that as we work, regardless of which side is retaining us, our goal is to elicit information in a sensitive manner that though we are not there with a therapeutic mission, is there, we're there certainly not with any intent to distress the evaluee. We want to put people at ease, be sensitive in our approach. It's very important that there are not limits placed on the scope of our evaluation. We seek to do a complete job, and that includes getting a background history. What is this person's family of origin? In fact, what was the nature of their mother's pregnancy with them? Were there issues going back as far as that? We're trying to understand this person's trajectory over time across multiple domains of functioning. And so we, in our forensic interviews, will cover things like a fairly detailed educational history and detailed occupational history, a relationship history, a sexual history, really looking for how has this person's life story gone and been impacted by this event that happened. Next slide.
And I want to note, folks, questions are rolling in. We appreciate those. We've got about 4 slides left, and then we will take a robust Q&A. So please do continue with those questions. Thanks, Charles.
Yep. So a little bit about our experience with multi-plaintiff assessment. And this actually goes for not just sexual abuse type of claims, though this would be true here as well. As Mark talked about, there's a wide variety of how people will respond to trauma. And what we would expect, and what we certainly have seen in these multi-plaintiff cases, is that there's a wide range, that there's some folks who, the most common thing we see is that people have some impact on them from an event, and that they are sort of incur a moderate degree of damage, so to speak. And what we see is on the tails of these curves that we do have, again, sometimes for reasons that are perhaps suggested by their history, people who are very severely damaged by the very same stressor. And conversely, people who are relatively unaffected, not that they're utterly unaffected, but that their functioning has been remarkably well preserved. So that kind of contrasts, though, sometimes with in these multi-plaintiff cases, and this is the next slide here, Nick,
Okay.
what we tend to often have presented to us, and you can imagine which side of the bar tends to present whom, is we see a barbell distribution that we're often presented, especially if there's a series of bellwether cases that are exemplars of a larger group. One side tends to push forward those that are most damaged, and one would be wanting to emphasize the lack of damage in the group. So that's a challenge we face. I mean, ideally, what we're seeing is actually a sort of random sampling of the folks who are affected, but sometimes what we're presented with, in fact, is something more of a bimodal distribution.
Whichever is more appropriate for whether it's the plaintiff or defense that is how I'm reading that. Is that accurate?
Precisely.
Okay.
Yeah. I'll turn it back over to Mark for the next slide.
Next slide.
Yep.
Okay. In multi-plaintiff assignments for which we're retained, more than in one-off retentions, meaning retention for a single case, single plaintiff case, there's some value added that we can bring based on our training and also our experience with the complicated logistics of multi-plaintiff cases. And that is, if we're retained early enough in the early discovery phase, we can help develop screening questionnaire documents, particularly if there's a reasonably large population of claimants. We can develop more than the standard form interrogatories, questionnaires that can be distributed for the purpose of trying to put into tiers the population of potential claimants, because as Charles showed with the bell curve, there's going to be a distribution from no damages to severe damages in most trauma, in most significant trauma events. And even though sexual trauma is different in some respects from catastrophe trauma, where there's a commonality, the oil refinery blew up, people were killed, burned, and frightened, and some of them developed PTSD. With a sexual predator, it approaches that when there's a single predator, such as some of the university cases where there's been a staff physician who has been sexually abusive to students. But if you have a group of individuals who are claiming sexual abuse by members of an institution, then there will be different perpetrators in that group, different teachers or different priests. And so it's not exactly the same story about the trauma, but nevertheless, screening documents can be very useful. And also drilling down and just when there is a single perpetrator or just a few, getting a familiarity with the MO of that individual. And one of the points that we usually make is that there is a ability to learn about the MO of the perpetrator by having a group of examinees, be they bellwether selected by some process or however it's selected, so that each person is a collateral informant for every other person, even though they have unique histories, vulnerabilities, and resiliency factors. They've had a common experience with the abusive physician at the university, for example, hypothetically. So pre-litigation, we can be very helpful in screening and going through whatever discovery data you have and trying to put these people in different tiers of people who definitely need to be examined in depth, people who probably don't, and whoever's in the middle. And it's usually that's kind of three categories. We're familiar with the logistics. I liken this to turning a aircraft carrier. Um, Arranging the examinations, the scheduling of a group of plaintiffs is a difficult task, and uh, it requires the ability to be flexible. Often it's out of town, so we have a limited window. We may be in a city for 2 weeks doing the testing, doing the interviewing, but so it requires a efficient method of how do we fill in canceled appointments, et cetera, when someone developed a toothache and they couldn't appear for their interview exam or for their testing. And to the extent that we can, we do the testing. Some of the testing assessment can be done in a multi-person setting, which leads to economies of scale. You can have a supervised MMPI-2 given to a group of people as long as the proctor is psychologically informed and knows what may or may not be responded to and how it should be responded to if there are questions. And then our testimony is invariably with sexual abuse cases, there needs to be testimony about at least the individuals who are part of the bellwether group. Um, it's not simply general testimony talking about sexual abuse in general or talking about PTSD in general to educate the trier of fact about what the diagnosis means. That's part of it, but it's got to be related to an individual. However, there is credibility that we gain with the trier of fact because we're a team. And we can say among this group, Mrs. Jones was significantly damaged psychologically in X, Y, or Z manner. But Mr. Smith was not and is really not functionally impaired. That adds to our credibility in being able to talk about the group, the arc of the population who had this common experience. Finally, class action lawsuits, as you know, is a subcategory of multi-plaintiff litigation, and a role that is important for us to be involved in is in the certification of the class, either correctly gathering data, and I've been involved where there's been really indefensible data. There's been data obtained by indefensible, biased, inadequate methods, which will never stand up to scrutiny in a challenged certification. So it's important if you're the plaintiff's attorney to get good data that is defensible, that's evidence-based, not quick and easy and cheap data, to be, crass about it. And if you're on the defense side, with emotional damages claims in class actions, there's a great deal of individual variability, the vulnerability and resiliency factors, the unique histories of the individuals. So although emotional damage claims can be an important part of like a product liability, a drug case where there's untoward damaging side effects from the drug, or possibility of cancer, or possibility of impaired fertility, and that has psychological consequences to which an expert such as ourselves can opine. It's difficult to sustain through class certification a class action where the main damages are psychological because there's so much individual variability.
I'll just add there briefly, Mark, that quite simply, our methodology in arriving at a diagnosis, we don't do that. There's not a way in which we accomplish that for a group that sort of just maps onto what you're saying, that there is individual variability. So therefore, in particular, sort of naming a particular diagnosis as the common emotional damages among a group without some evidence that there was actually an individual determination that that is in fact the case just doesn't hold water from our perspective.
And in fact, it's unethical for any physician to offer a diagnosis without an examination, if an examination is possible. If the party, the subject of the examination is deceased, obviously you can't examine them. If they're remotely in prison and there's no way to access them, you can't. Or if the court says you may not examine them, then you give an opinion, but it's qualified by the fact, and it's an important and limiting qualification, that no examination took place.
Excellent. All right. So I think that's the presentation aspect, and it looks like we've got some good questions here. Are you guys ready?
Absolutely.
All right. So our first question is, and I'm going to post that. Are you able to see that?
Where would we look?
Should be on your screen. Well, let me read it to you. It says, can you give examples of the sort of information and or questions you would look for or find most useful within deposition testimony when acting in a forensic role?
I can take that.
Okay, go ahead.
I think I hope I'm understanding the question. You're talking about what is useful to our eyes when we read a deposition within the context of litigation. And of course, reading the deposition of the plaintiff is very important, because although it's in a formal context and a very different kind of communication than a psychiatric interview, it is a subjective narrative through a Q&A process of the plaintiff's perspective and some prodding around the edges by the deposing attorney. So you get a sense, and often a videotape of a deposition is even more informative because of the nonverbal communication that is very important to how we gather data. Let me just say something as an aside about that. For a psychiatrist, the facts are only a piece of the data that is being examined. The manner in which those facts or statements or subjective beliefs are presented are equally informative, as is the content of what's being said. So videos are very interesting to us, say of a deposition, because we see the nonverbal communication and what's going on. Is the person comfortable? Are they calm? Are they increasingly uncomfortable? Is that the moment when they suddenly get the headache and have to interrupt the deposition? All that's very interesting and relevant data for us to observe and try to make sense of. The point is, how does this data for us fit into supporting diagnostic impressions from which flow prognostic conclusions, treatment recommendations, etc.? So the last part of this, apologize for being long-winded, is many depositions are witness statements, basically. They're better than declarations because they are prodded and explored by the deposing attorney. And that is the Japanese film Rashomon, in which a story is told like the spokes of a wheel. And you get different perspectives, different subjective realities of what ostensibly, objectively happened from the different observers. This is like eyewitness reports, which are not literally reliable, but are contextually informative. That's probably a best way to judge it. And so having co-workers, family members, etc., being deposed, the spouse, is giving us collateral information about the subject of our investigation and analysis.
I'll just add after Mark's sublime reference to Kurosawa, I'll go to the very mundane. Just another dimension of what we pick up out of a deposition is sometimes things like, oh, we don't have the records from this, and sometimes, I mean, that does like come up that's actually, for whatever reason, a hole that nobody else has sort of picked up on, or that, boy, there ought to be records from this, or that kind of thing. So sometimes it is, again, quite mundane, but we're actually sort of, understanding, we're getting sort of data points of what this person's arc is. And sometimes, knowing that we need to explore this in our interview, we need to get the records from this particular experience. Boy, it would be important to understand what this person's performance at college was prior to the transfer, to the other university, for instance.
Excellent. All right. Our next question, and please, folks, keep them coming. We've got a good 40 minutes here to answer your questions. We've got some good ones. We've got the next one is, in the threshold criteria for PTSD, can you explain what qualifies as sexual violence? Charles, Mark, who wants to take that?
So I'll step in first. I mean, it obviously is not some clearly like bright line definition per se. And I think, I'm actually just trying to quickly in my head refer to the literature to think whether that's been explicated. Mark, if you know of some literature that sort of talks about what criteria, or I'm sorry, what events fit that criteria versus not. I would certainly say, though, that
I think it's more the Potter-Stewart principle. Obviously, rape with a weapon, with a physical assault, is violent. That doesn't mean that molestation that involves grooming and seduction doesn't have damaging effects, but it's not forced. It's not with other physical damages or the threat of other physical damages in which the person either has been injured or submits because they're afraid they're going to be injured.
Mm-hmm. I will just call out that at times in child cases, the context again, or the sort of nature, the configuration of the abuse, that, for example, two children who are of markedly different stature, right? There could be a real perception of sexual violence if one child is molesting the other child, or even engaging with something. Obviously, it's not consent, but some sort of assent by the victim. Even that sort of encounter could be violent in that sense.
Okay. Yeah. Thank you for the questions, folks. Next one up, and this kind of goes to that treating physician versus the forensic, independent forensic expert. If, as a treating physician, you accept a patient's report, how do you diagnose delusions?
Oh, that's a great question.
It's a really good question. Maybe I'll take that
go ahead,
first, but I chime in as well. So it's, first of all, in the context of what we're describing, we weren't necessarily thinking of the clearly psychotic individual where delusions are in play. But I will say that even I work a lot. In fact, the sort of bulk of my clinical practice involves people with serious mental illness that often involves delusions. We are able to identify delusions by their gross incongruence with reality at times. There are other times where it isn't so easy. and I will say that there are times literally in a treatment conference where we actually aren't able to sort of definitively determine whether somebody is delusional and versus this actually being a sort of credible report. So Mark's reference to the Martian pointing a ray gun at somebody, that's usually fairly clearly delusional. However, there are times where our patients will say things to us in clinical context where we actually aren't able to get at the ground truth of whether that statement per se is delusional.
Excellent. Okay.
Could I just add something?
Yeah,
Because this,
sure.
um, there are there are diagnoses, let's say paranoid schizophrenia, where delusions are gross and are obviously false beliefs. But there are other diagnoses like delusional disorder, persecutory type, which is also psychotic, but the people present with non-bizarre delusions. They can be of persecution, they can be um, delusions that a celebrity is in love with them. And um, they are non-bizarre, they could be true, and it takes a lot of drilling down. And uh, I was once involved in civil cases that flowed from a serial killing at a workplace in which the individual was a functioning technician, and it's kind of went postal. He went to his workplace and fully armed and shot a bunch of coworkers, and superficially was not in the street screaming like a homeless person who may be psychotic at the moment. And if you asked him about his passion, which was taking apart and rebuilding engines of some classic cars, he could tell you coherently, rationally, making good sense exactly how that's done. But if you drilled into what he believed, that his coworkers were sabotaging the parts under the direction of the vice president in Philadelphia, so that his uh, site repairs of equipment was going to be a failure and therefore bring shame upon himself. You then get to the very crazy things like his coworkers. He had a hobby of raising koi fish, and he believed his coworkers were molesting his fish. So there you get in, when you drill down through the non-bizarre delusions, you start to get to the crazier edges. And then you say, aha, finally, this is where robust testing is very useful, because MMPI-2 with its 8 or 9 validity scales combined with other tests, uh, Rorschach in particular, for picking up underlying subtle psychotic thought processes, um, give evidence that's much better than the standard of proof to which we testify, preponderance of the evidence. It's in the 90s plus percentile of accuracy. So when we get this test data, it's really supportive of our opinions. We have a lot of confidence in our conclusions when the test data supports the clinical implications.
One other thing I'll just add on the topic of delusions is that one of the features of delusions is that they persist in the face of incontrovertible evidence to the contrary. So that is one way in which we might sort of arrive at some sense that for example, my case manager bought me 10 hamburgers at McDonald's yesterday. Well, if we sort of actually find out that the case manager was not at work, and therefore this event did not happen. Oh, okay. And then the person, no, in fact, no, they bought me. It was yesterday. I could tell you, we went to the McDonald's on 89th Avenue and we were in the drive-through and she ordered 10. They wanted to give us 11, but we only got 10 in the end. Okay, that's probably delusional at that point.
Great. All right. Our next question is: you referred to educational fall off as a sequela of sexual abuse, but this is not always present. Indeed, you will find victims of abuse who are extremely high achievers. Is there a survey of how often which result is seen? And is this correlated to PTSD versus more resilient response? You let me know if you need me to repeat that one. It was a little.
I pulled up the Q&A so I could see
it.
it.
You see it.
If you pull up
right.
the Q&A, you can read them also. Yep. Mark, do you want to go first?
Sure.
Okay, go ahead. Yep.
So all of the DSM-5 diagnoses have as one of the essential criteria functional impairment. So, and that's in fact an area that we as professional skeptics, regardless of which side of the bar retains us, are looking at. How functionally impaired or unimpaired is the individual? Because um, I'm not an attorney, but my understanding is that in civil litigation, what is compensated is impairment. So even if you've been through a terrible experience, if you're functioning just fine, it's difficult to make a case that you've been damaged. And so when you have someone who's been through uh, undoubtedly abusive sexual experience, and they are very good academically, you would look at other areas. You know, they may be doing well in areas of objective achievement, but may be doing very poorly in interpersonal relationships, particularly intimate ones. And you'd want to look there and see, is their basic trust impaired? Are they afraid when people get too close to them, etc.? That would be an area you might find that they're not achieving so well. They're below the grade, you know, for their education, social background, etc., then you would expect someone who had not been traumatized. And then the other issue is that you can often see in test data um, evidence of underlying turmoil, chaos, and trauma. I very briefly, many years ago, I was involved in a case. It wasn't sexual abuse, but it was a severe trauma in which a family car went from park into drive and crushed the imminently pregnant and getting ready to go to the hospital for delivery mother's abdomen and ruptured her uterus. It was a terrible trauma. Ultimately, the baby about to be born exsanguinated and had huge effects on their lives. When you gave them the MMPI-2, which is an endorsement test, they both said, in effect, everything is fine. In fact, I was a plaintiff's expert in this case. Everything is fine. They were very tough, pull yourself up by your bootstraps kinds of people, and religious people, and believe to some extent tragedy was God's will and therefore should not be opposed. When you gave them the Rorschach, both of them, both the husband and wife, you saw enormous turmoil, chaos, trauma, anxiety underlying the surface. So you have to dig deeply, I think, is the answer. What may superficially appear to be everything is fine and the person is achieving without interruption, it may not be, in fact, the case once you get to dig down to lower levels.
Yeah, I'll just add to that, that's why we gather these multiple streams of data, because it may be present in one. You look just at educational records and you infer this child is completely fine. Could be the case that in fact they're remarkably resilient, and in fact they had a home which was validating of what happened, and they got good treatment, and the kid is relatively unaffected. But PTSD could be showing up in a different domain of this child's life, that they literally are cut off socially from friendships and activities that they used to be involved in, and maybe are channeling all this energy into school. There's a way in which we could easily miss the overall story if we're failing to sort of glean these various streams of data.
Great. Charles, one thing, when you're touching the desk, we're picking up those noises.
Oh, pardon me.
I just wanted to let you know that. But that's excellent. I was thinking, well, maybe they no longer want to play sports, and they really are kind of becoming isolating, and maybe that is indicative of what you were just describing. Our next question is, Our treating psychiatrists, and thank you folks for all these great questions, and please keep them coming. We've got about another 25 minutes here, and it looks like we're filled up. Are treating psychiatrists not qualified to assess whether abuse has happened? I think this goes back to that treating versus forensic.
Mark, you want to maybe weigh in first? I think I understood the question, but maybe you have a crack at it first, and I'll give it a little more thought.
I think if you take this literally, neither treating nor forensic experts are qualified to answer an ultimate question, which is really the fact finder's question: did this occur or not? The best that I would say that if you're comparing the roles, a treating psychiatrist is not an independent expert. They are an advocate, and they have generally much more limited data supporting their conclusions, and much more subjective data. A much larger percentage of it is subjective data than an independent expert. So in that sense, but even as an independent expert, it would take remarkable facts for me to say with conviction, immediate post-rape vaginal swab showed semen, the DNA of which belonged to the accused rapist. That's pretty good objective evidence that this person was raped, and was raped by the accused individual. But in a sense, like in everything, I'm relying on data to support my conclusions. That's not a psychiatric opinion per se, and in fact, you wouldn't even need an expert probably if those were the facts, because the jury would understand those facts without someone explaining it who had expert skills. I'll turn it to you, Charles.
Yeah, I think it's rare that that's not usually the question we're being asked as a treater, but certainly for this purpose as a forensic expert, to sort of give a frank opinion about whether abuse happened. I think in responding to Nick's question earlier about validity of reports, we might elicit something that suggests, gosh, there's a lot of different stories about what happened here coming from different sources and so on and so forth. But I don't think I've ever had that question per se been something that I've been asked to offer an ultimate opinion about.
Excellent. And I see a question down here as to providing the contact information. So I have put that slide back up for folks to find Dr. Levy and Dr. Saldanha's contact information.
One thing I will just add really quickly is
sure.
that, particularly in the child claims, folks may be aware that it's very important. This is actually true for any sort of forensic interview, but there's a very important skill set that interviewers of victims of child sexual abuse bring to the table in assessing what happened. I'm talking about in the context of investigation of these complaints and so on and so forth. So particularly some of our child psychiatrists on our team, have experience with looking critically at how information was elicited and so on and so forth. So again, it's not maybe the actual question of did this abuse happen or not, but they can maybe speak to how information was elicited and whether it comports with an appropriate way of working with a child based on their developmental age and potentially other factors.
In that regard, 2 of the 12 psychiatrists in our group are board certified in child and adolescent psychiatry, as well as adult, as well as forensic psychiatry. And they have not just the training, but deep experience in assessing allegations of sexual abuse in children. That doesn't preclude Dr. Saldanha or me from evaluating an adult who's claiming abuse that happened years ago when they were children. Although the child forensic psychiatrists bring an added sensitivity to early developmental issues. But it does make them very experienced when assessing children or minors. They don't have to be 7-year-olds. They could be, 16 or 17 years old. It makes them very experienced in assessing sexual abuse claims, in that age population. And we automatically defer to them when there's a minor involved in a claim.
Great. This is an important question because we see this come up with experts from time to time. There's always discussion about that. It's in practice, how independent are these assessments? Aren't they colored by what side, plaintiff or defendant, hires the expert?
Yeah, it's a great question. And really, our methodology doesn't vary depending on who we're hired by. And our goal, and we find that most attorneys we work with are interested in hearing what's there in the case. So, it's always best to have an attorney that's retaining you who genuinely wants that. But certainly, even when we're experiencing a little bit of kind of nudge from the retaining party, our goal is to remain independent and objective in our determinations. Ultimately, that's what we do, and I don't think it represents us or our field well when we try and shade it one way or another based on what we think the person hiring us would like us to say. And, frankly, in the adversarial process, it probably wouldn't hold up very well if we're saying something that is in some way not supported by the data and evidence we're reviewing. Mark, do you have anything to add?
Yeah, I do. I want to tout the training and the significance of board certification in forensic psychiatry. And here's why. First of all, there are only slightly over 1,300 actively practicing board certified forensic psychiatrists. There are almost 50,000 psychiatrists who are board certified in the country. And many non-trained, non-board certified forensic psychiatrists put themselves out there as forensic psychiatrists. And they are, in fact, they often don't make the distinction, the role distinction that's so important between being independent and being an advocate as they are naturally for their patients, or as we are naturally for our patients, but not when we're. So what happens is in training and in all of the continuing medical education thereafter, there's a mother organization called the American Academy of Psychiatry and the Law that forensic psychiatrists belong to. We are in a very nuanced field, and we need to understand our biases. No one is bias free, but we need to understand them. We need to understand the ethics of what we present as our opinions. And there's a trough. So if I find something that would be, let's say I'm a plaintiff's expert and I find something in my interviewing that may be derogatory about the plaintiff, but is not germane at all to the questions I'm being asked to opine about, I'm under no ethical obligation to offer that information. And in that sense, I'm exhibiting some degree of bias of trying to help the side that retained me. If it is relevant, I am ethically obligated to present that information. I may try to explain it, but I need to present it. If I'm asked it, whether I think it's relevant or not, I need to answer that honestly. There are many nuances of ethics that we deal with as forensic psychiatrists that are not present in clinical practice. In clinical practice, you don't sleep with your patients, you don't get into business deals with your patients, and a few other things, but that's about it. In forensic psychiatry, you got to deal with, well, you want to be liked by the attorney who's retaining you. You wouldn't mind having future business from them, but how much do you let them seduce you into being an advocate for their opinions. And so one of our esteemed teachers says, the role of the, and this is the difference between being trained in forensic psychiatry and not, the role of the forensic psychiatrist is to vehemently defend the truth of your opinions against the seduction of the retaining counsel and the oppression of the opposing counsel. And although that's a hyperbolic statement, it is a very good sort of mantra for us to keep in mind in terms of not being a tool of the side that has retained us.
Right. And thank you, folks. We're getting some upvotes on the question. So if there's a question that you also like, upvoting, it helps me see which ones folks are most interested in having answered. Our next one is, do you have a way to evaluate the impact of a specific incident of adult sexual abuse when the individual is also a survivor of extensive childhood sexual abuse? So I'm understanding that as abuse from two separate times in the life.
Yeah, that's a great question, and it's not an uncommon challenge that we're faced with. And we didn't get a lot into sort of the historical factors and so forth, but it is sadly the case that there are people, by virtue of their circumstances, and to some degree perhaps by virtue of what types of situations they may end up putting themselves into as they go forward in life, who are serial victims of sexual abuse. That carries with it a couple of factors. So clearly, previous episodes of abuse may have had some effect on that person's psychological well-being. They may have, in fact, even had diagnoses like PTSD, and in fact, bona fide PTSD that sort of meets those full criteria that Mark explicated as by virtue of one of those. However, the incident in question, let's say we're being asked to now evaluate what are the consequences of, I'm going to try not to hit the table. I think I'm doing it again.
You are.
I'm very, my passion is my enemy with respect to that. I'm going to have to get me handcuffs or strap my hands to the arms of the chair here.
But he's a good witness in the courtroom.
Sure.
But what I'd say about the sort of context of previous abuse and evaluating a current episode is that it can, in fact, predispose the person to be more adversely affected by what happened this time around. That there is sort of if not frankly, a straw that broke the camel's back, like literally that they were doing fine and then this brought them down. That a person with a previous PTSD, even if it was successfully treated, is potentially more vulnerable to PTSD. And that would be true of depression as well, that if that was the sequela of the initial episodes of abuse, one would expect that this person would be all the more vulnerable and likely to experience abuse. Now, it's your point, though, Sarah, is that it can be really delicate and difficult to tease apart. Again, we would want to be looking at multiple streams of data about what was this person's treatment history prior to the incident? What was their functioning in relationships like prior to the incident? What was their occupational functioning prior to the incident? And how has that changed? So a great question and actually a very common scenario.
At the risk of taking up too much time, I just wanted to add 2 points to that.
Okay.
To your excellent answer. In addition to prior sexual abuse being, in fact, literally a predisposing vulnerability factor for subsequent PTSD, assuming they had PTSD in the past, but it's a reasonable assumption if they had ongoing sexual abuse. I think you said extensive childhood sexual abuse. There's another subtler issue that you would be well to be aware of. Extensive childhood sexual abuse is damaging in a variety of ways. It may cause other diagnoses. Borderline personality is one of them. It may result in an adult who is sexually seductive, who wears, it could be a man, but let's use a woman as an example, who wears revealing clothes to work and is literally blamed implicitly or explicitly, for the sexual abuse that occurred in the workplace with her supervisor. And it's not the facts, it's how you present the facts that are important. This may well be an eggshell plaintiff vulnerability factor that she had, that because, and here's why, a person who's been sexually abused is distrustful that anyone will value them for who they are rather than for their sexual appeal. And they unconsciously test this repeatedly. Will you rape me now? Or will you try to seduce me now if I have a low-cut dress or a short skirt, etc. And that enactment unconsciously of how safe is this environment may make them more vulnerable to the predator in the environment, but it isn't that they were asking for it. It's that their prior psychopathology, as a result of there being an eggshell skull plaintiff, has made them, in fact, a more likely victim.
Okay, that's great. Okay, we've got this one from Daniel. Can you discuss, and we've got about 10 minutes left, so we may not be able to get to all questions today, folks. Please upvote those ones you need some answers to. Can you
contact us?
Contact us.
Or reach out
You're
to
welcome
Charles
to.
and Mark, please. And you should see their information on your screen right now, their contact information. Can you discuss adjustment disorder and how it relates to damages? For example, this person's got a client who was abused by a teacher who now has a severe eating disorder and has required residential treatment. She had some body image concerns prior to the abuse. Is that an adjustment disorder? And how do we prove that it was caused by abuse?
Let me take the latter part. Well, actually, the early part of the latter request. There's the discussing adjustment disorder.
Sure.
Is that an adjustment disorder? What I'm inferring from this description of the scenario is that actually we wouldn't call an exacerbation of another diagnosis, a severe eating disorder, say anorexia nervosa or bulimia nervosa. That's not an adjustment disorder. An adjustment disorder is an independent diagnosis. So it's not you had a worsening of your schizophrenia, a worsening of PTSD. That's not what we're talking about here. An adjustment disorder is a stressor-related, generally time-limited condition. And if you look in the DSM for the adjustment disorders, they really are, there's a number of flavors. It could involve a predominance of mood symptoms or a mix of mood and anxiety symptoms. So when we're talking about adjustment disorders, we're really talking about changes in functioning and psychological health that are clearly related or seem clearly related to a particular stressor, generally temporally and sort of by virtue of the content of what's sort of informing the complaints at that point, that are not meeting criteria. So in the case of sort of like an adjustment disorder with depressive type features, not meeting criteria for a frank major depressive episode, and are time limited and generally sort of resolve as that stressor passes. Okay, so just to contrast it with that scenario again, it seems, Daniel, that what you're describing there is actually somebody who had an exacerbation of a different diagnosis. We wouldn't call that an adjustment disorder.
Great. Great. Okay. And our next one from Jill. Can you please discuss how prior history of trauma, or ACES, which I'm supposing you guys know what that refers to, impacts emotional distress damages? If a plaintiff has less resiliency due to his or her history and therefore has more severe reaction to sexual abuse, does this lead to higher damages or lower?
Charles, you want to?
Well, I'm actually frantically Googling ACES.
Yeah.
Adverse childhood experiences. Is that
Right.
what we're referring to there? Okay. Yeah.
That sounds accurate.
Yeah, I think that sounds right.
That's what it is. That's what it is.
That's what it is. Yeah.
Mhm.
So, we aren't at the end of the day. Damages vis-a-vis how they play out in civil litigation. We don't decide that, right? And
Right.
we might provide some information about what we think likely impacts on functioning, likely needs for treatment, and so on and so forth are. I think a generic answer to this would be that it kind of depends, right? That there might be, so let's take those two dimensions. How is this likely to impact functioning, and how is this likely to impact treatment needs? It may be that this person had fairly well recovered, um, uh, and from these early childhood experiences and was functioning fairly well, but is actually affected such that their need for treatment and the impact on their functioning going forward is significantly greater than what would be uh, seen perhaps with another a person. It also could be the case that this person with trauma and these adverse childhood experiences is actually struggling quite a bit already. And it may be that they've had this additional traumatic incident, and though they are continuing to struggle, and that it's not that this additional incident is irrelevant, their trajectory isn't so much altered because their needs for treatment and their degree of functional impairment was already quite high. I don't know if that makes sense. Mark, I don't know if you have anything to add as well.
No, I thought that was, I thought you covered the,
Yeah.
all the bases. The only thing, what you're saying is there could be an exacerbation of prior vulnerability. And to the extent that the exacerbation is the liability of the defendant, then, then that it will constitute damages, whatever the dollar value put on that, to the extent that they that the prior damages would have been there regardless of whether the intervening event that gave rise to litigation occurred, and would have needed treatment regardless. That becomes a more difficult argument to defend, that but for the event, this person would have been fine and wouldn't have needed treatment.
Okay. And this one seems similar to me, but you guys will tell me if that's accurate. Carrie asks, how do you determine a level of impairment for an individual who was impaired to begin with? I'll start with that and then maybe hit the second part of this question.
Well, I think it's a parsing question. Someone's impaired to begin with, then something happens, and then they're impaired afterwards. How do you parse the post-incident impairment, to attribute a portion of it to it's an apportionment question, to the intervening event versus what was there before? The simple answer is it's difficult. But the combination of learning as much as you can about their history from prior records, depositions, and the interview of them, even though that's a subjective narrative, will enable you to see how their functioning was impaired prior to the incident, and then how their functioning was impaired subsequent to. And it is a smoke-filled room for us. This is not a clear view with, you can see the horizon 20 miles away, because the adversarial process of litigation attempts to, as much as possible, the advocate for this individual wants to say, but for the incident that happened, things would have been acceptable, that they were functioning well enough before, and now they're not functioning at all. And the question for the professional skeptic, and particularly if you're a defense expert, will be to say, is that true? How well were they functioning before? And try and get as much data as you can. Sometimes test data can be informative about that, by the way, not just history taken from the individual in an interview.
Mm-hmm. I'll just add that sometimes it's rather than quantity of impairment, we may also see either a consistency or change in kind of impairment and or complaints. That it would be one thing if the sort of issue of a bad marriage is sort of present in sort of dominant in the themes in the records prior to the incident, and sort of continues to be the major thread afterward. We see that sometimes. It's a whole other thing if this person has been sort of dealing with certain types of stressors and complaints and so forth, but there is a marked inflection in what the topics of concern are and perhaps the domains of functioning. So yeah, maybe let's switch it to a bad boss. And that's been my problem all along. And then the focus becomes recovering from this horrible experience I had, with my yoga instructor. That's a change in sort of nature of complaint. And then maybe the kinds of complaints that this person was describing, issues with sleep and anxiety in the workplace, and is now dealing with a great deal of problems with sexual functioning, is socially isolating, things that actually weren't so much the problems before.
Right.
Just quickly, it also depends on the nature of the diagnosis that the evidence supports, because diagnoses have a natural history. Just like congestive heart failure goes on for years. It's a chronic condition. It has symptoms attributable to it. And an intercurrent event could be the straw that breaks the camel's back, but it could also be just an intercurrent event, and the pre-existing congestive heart failure symptoms continue post-incident.
Great. Gentlemen, we are out of time. I'm sorry we didn't get to all your questions. Thank you to all our attendees. Please, if you have additional questions, you see Dr. Levy's and Dr. Saldanha's email, forensics@fpamed.com. I think they'll be very happy to hear from you and be willing to answer questions there. That's at their website is fpamed.com. Gentlemen, any last thoughts before we wrap up for the day?
I want to thank everybody who's taken significant time out of their day to listen to us, to attend this. And I want to thank you, Nick, very much for giving us the opportunity and hosting this.
Oh, pleasure. Pleasure. Always good to see you guys.
Thanks very much. It's really been fun, and I appreciate the excellent questions.
Yeah, thanks so much, everybody. Please, again, if you have questions, reach out to Dr. Saldanha and Dr. Levy at fpamed.com, and the email is forensics@fpamed.com. And with that, gentlemen, I will wish you a wonderful day.
Thanks again, Nick.
Thanks,
you.
Nick. Bye-bye.